Assalamu alaikum wa rahmatullah. Good evening, everybody. I'm very happy to be here with you, um, where we are going to talk about a very important topic, which is a hypothyroidism. And why did we choose in primary care setting? Because we believe that in most of these cases are diagnosed by a primary care physicians, whom they are the first line who are facing those patients. So I'm Saudi Sifri from Al Hada Armed Forces Hospitals. I'll be happy to moderate this session, which is sponsored by Merck and endorsed by a Gulf Association of Endocrinology and Diabetes. So tonight it is going to be accredited again by Dubai Health Authority. So once we finish from this, uh, most probably tomorrow you will get your certificate. So I think this is an important issue. Uh, Now, again, I would like to invite you for registration and becoming a member in our Gulf Associations of Endocrinology and Diabetes Society. So you can just scan this code where you might be a member in the society, so that you will get all the updates, newsletters, and you can be from there. So once you scan it, again, this is an open invitation for our annual Gulf Association of Endocrinology and Diabetes Congress, which is going to be held on 24th and 25th of October in Dubai, Conrad. So everybody is welcome. You can just scan the code. Now, to start with this, always thyroid has got many things to be linked to. So tonight we'll try to cover most of this. So we would start with thyroid and cardiovascular disease, and then how we would look into those subclinical and overt hypothyroidism, and then we will look how to manage those cases, especially in special population group. So we are going to start really with one of our eminent speakers and colleague, Dr. Job Simon, who is a consultant endocrinologist at Burjeel Hospitals in Abu Dhabi. So I think most of you would know that Dr. Simon is an endocrinologist and internist whose special interest in clinical endocrinology, where he had an internal medicine training at State University of New York, Stony Brook, and then he had his endocrinology and nuclear medicine training at, again, New York University, and Memorial Sloan Kettering Cancer Center in New York. And he was working initially at Tom and Mafrag hospitals in the UAE, and now he's working at Burjeel Hospital in Abu Dhabi. So we would like really to hear from him what are the associations between thyroid and cardiovascular disease. So please, Dr. Simon, the stage is yours.
Thank you. Thank you so much, Dr. Sifri, for that nice introduction. I'm just actually flattered to be here, because I think most of the audience and definitely all the panelists know much more about this condition than I do. But I would like to keep it as a more open discussion, maybe in the later part of the lecture, where we can all discuss or share our experience. Why do we decided to talk about hypothyroidism? Mainly because it is probably the commonest disease, that chronic disease, that we see in the clinic. In fact, there was a survey in US, and they found that the commonest disease in primary care clinics is actually joint pains and arthralgias. And after that seems to be thyroid issues. If we include hypothyroidism and thyroid nodules, then we will see that it's actually so very common. And the presentation is kind of very, non-specific, very subtle. So we need to keep a very high index of suspicion for almost everybody who walks into the clinic. A case can be made to check everybody who comes to the clinic with a simple TSH. Of course, the government and the insurance companies would not be willing to accept that without showing the cost benefit analysis in the health economics calculation. But even then, I would like to recommend that keep a very low index, I mean high index of suspicion, and be very much ready to order a TSH whenever you suspect, because you do not really want to miss a hypothyroidism, which has happened to me many times myself, in spite of being an endocrinologist. So especially in young men, because they generally tend not to seek any help or consultation when they feel tired. Now, what do you? I mean, just forgive me for going back a little bit for to the basics. Just I'll run over it quickly. Of course, we all know this. It's triggered the master metabolism control of the bodies from the pituitary, which is controlled in fact by the hypothalamus, and from the anterior lobe of pituitary we have TSH getting secreted, and there is of course a diurnal rhythm, but it's not really very significant, and it leads to production of T4 and T3 from the thyroid, and this in fact causes a feedback onto the pituitary and hypothalamus, and this is how it is controlled in the body. So what do we do to check the thyroid? TSH is actually the most sensitive indicator, mainly because it is a log linear relationship, meaning when the T4 goes up a little bit, TSH goes down a lot. Or when the T4 goes down a little bit, TSH goes up a lot. So this is what is known as the log linear relationship. It's actually not very strictly log linear. I mean, there is a difference. As we get older, we tend not to react so well. I mean, TSH tends to go up much less in elderly in relation to a lower T4. But then again, we will be much less likely to treat an elderly person because TSH up to 10 does not seem to affect elderly at all. So we do not really need to treat a slight elevation in TSH in elderly, but that will be discussed in detail by our experts. I just wanted to say that if we have to check to do one test, the test that we would pick is TSH. Of course, the best thing would be to have a TSH and a T4. If we can get both of these together, that'll be fantastic. We will be able to pick out almost every thyroid condition, hypothyroid case, or even hyperthyroid with that. And most important is not the fine details, it's actually just the detection. Once we have a detection, and if the numbers do not make any sense, your friendly neighborhood endocrinologist would be there just next to everybody's clinic. So if somebody is not very sure about what the numbers mean in the thyroid test panel, please refer to endocrinologist, or at least just repeat it in a few days, and we will see. Now, what about early mild hypothyroidism? That will be discussed in detail a little bit later. But there are like so many causes of hypothyroidism, but vast majority of cases we take in the world generally is actually used to be low iodine, so iodine deficiency. But luckily with salt iodization, that has mostly been taken care of. But there is some evidence that there is actually an iodine deficiency creeping back in Europe even. So in many parts of the world, we do have a little bit iodine deficiency, even some parts in our areas itself. But majority right now is actually autoimmune. And in fact, when the ambient iodine intake goes up in the population, the autoimmune condition seems to increase, autoimmune hypothyroidism. Of course, there are some medications which can do this. Of course, we all know about lithium and amiodarone, and even a lot of these newer tyrosine kinase inhibitors, they tend to create even autoimmune hypothyroidism. They can even cause destructive hypothyroidism, but we will not go into this minor subsegment. 80% of cases are actually autoimmune, which is Hashimoto's thyroiditis. Very simple to manage. So what is the prevalence? Depends on which part of the world we look at. Even in UAE, there is a huge difference between different Emirates. In Abu Dhabi, luckily, it's much less. In the Emirates of, let's say, Ras Al Khaimah and Fujairah, the prevalence is so much more. Got to do with the ambient iodine intake and iodine metabolism in that part of the country. Most areas where you have like near the shore, you would see a much higher prevalence of subclinical or even clinical hypothyroidism. And if it's subclinical, whether to treat or not to treat, that will be discussed in a little bit detail later. But if there is overt hypothyroidism, there is no doubt we have to treat. And why? It's actually, I put the obesity first because that's the most common problem that I see in the clinic. Almost everybody who is overweight or obese tends to come to the endocrine clinic thinking it is the thyroid. Actually, it's very rarely the thyroid. Only about 5% of cases of overweight obesity is due to hypothyroidism. Vast majority is not. But we do pick up a lot of thyroid dysfunction just from people coming in to check the weight condition. Okay, so but there are many important situations such as in pregnancy or somebody who has a cardiovascular disease or somebody who is having, especially very, very commonly, somebody having mood disorders. These are the people, the average patient who comes to you in the clinic and say, I'm feeling depressed, not feeling happy, I'm feeling stressed out. This is the kind of patients, because cognitive dysfunction and mood disorders are actually the commonest present in situation. And in fact, it is almost an adage in almost all psychiatric centers that any patient before admission needs to have a TFT before they can get admitted in a psychiatric hospital. Of course, goiter, or if somebody has a family history of thyroid disorder, definitely we must check it. And why should we treat them? Is because it is not as innocuous as we used to think. That it's not just overt hypothyroidism, even subclinical hypothyroidism has been shown to be associated with actually increased cardiovascular morbidity and even mortality. There is in fact a much higher incidence of coronary heart disease. There is also increased incidence of heart failure and increased mortality. And that is got to do with multiple problems going on in the CV system. The basic problem that we often see is that there is increased systemic vascular resistance, which is very evident because there will be a higher diastolic dysfunction and higher diastolic blood pressure. This got to do with reduced nitric oxide synthase. Of course, we all know that in severely increased hypothyroidism, you would see that there can even be pulmonary, pericardial effusion. I've seen only 2 cases of pericardial effusion in all these years. That's very rare. But diastolic hypertension is very common. Depressed diastolic and systolic function is very common. So the problem is that it actually translates to mortality. And most of the big data sets, over 500,000 patient data sets that has come from US and UK have shown that there is increased mortality rate associated with subclinical and definitely overt hypothyroidism. So it needs to be treated. And this is just the data that which is underlying this. I just want to show you, just focus on this area. Once you have a TSH, 7 to 10, you already have a higher hazard ratio for CHD events. But when you look at the mortality is like 40% higher. And for heart failure events, the hazard ratio is 65% higher. Really, really significant. And it's something that is very simple to pick up. So feel free to check TFT, anytime we have a suspicion. And especially the role of anti-thyroid antibodies comes in very, very important in this scenario, not just in pregnancy, but even otherwise. If they have high anti-TPO antibodies, we know that the rate of resolution of even mild hypothyroidism is much less. So these are the people, even if we do not start treatment, we need to monitor them very carefully, because they have almost a 50% chance that they would progress to overt hypothyroidism. Of course, remember that 50% might revert back to normal if the TSH is below 7. So we do not have to treat And most important, do not treat based on a TSH only. We must always do a free T4 before we start the treatment. Now, what are the other conditions? There is increased total cholesterol and LDL cholesterol related to hypothyroidism. That's mainly because LDL receptor, the numbers of them are reduced and the efficacy is reduced. So the LDL tends to circulate in the circulation. So we see a higher LDL and translate to higher rate of atherosclerosis. There is more total cholesterol. Triglycerides also seems to be going up a little bit. Of course, there is not too much increase in lipoprotein little a, but there is actually increase in hsCRP. There is also increase in homocysteine, which are also indicative of higher cardiovascular risk. So even slight increases in TSH actually reflects in higher dyslipidemia. And more than that, I mean, what about type 1 diabetes or Addison's disease? Any autoimmune condition, we need to make sure that we check the TFT because they do have a very high risk. And this is type 1, but in fact, in type 2 diabetes, it can actually make diabetes control worse if we do not treat it. That's because there is hypothyroidism, even at the subclinical stage, is associated with insulin resistance. And even in many studies using HOMA measurement of insulin resistance, which is much higher insulin resistance. And if you measure the baseline insulin levels, tends to be higher in patients who have hypothyroidism. So even for diabetes, if it's finding it difficult to control diabetes, it may be worth checking a TFT. Of course, most endocrinologists are in the habit of ordering TFT very often, but this is just for the primary care, that because you do actually see so many more patients in primary care than the endocrinologists. We do see, at the most we see 40% thyroid cases in a city. I mean, 60% is definitely managed by the primary care. Of course, I did mention obesity. It needs to be said that everybody who has obesity deserves a TFT, even though that 90% of them do not have hypothyroidism, which is causing the obesity. Most of the time, it is actually genetic or related to oral intake. Now, this is the mechanisms which are proven to be causing cardiovascular risk in hypothyroidism. Mainly, there is a downregulation of the renin-angiotensin system, and there is a reduction in cardiac output. Mainly, not just because of lower heart rate, is much more important that is actually because of the lower stroke volume. So, and when we treat it, it does get better. Just we have to be careful not to treat at a very high dose. Start with a lower dose and go slowly, especially in elderly. I did go over these molecular mechanisms, but I also should mention that as the TSH levels go up, it is actually a linear. As the higher the TSH, the much more likely that the total cholesterol tends to be going higher and higher. And just a word about the other organs, because we do not have a session on the renal or the GI. So I'll just put one slide each. This is in the renal situation. There is actually an elevation in serum creatinine. We do not need to panic about the high creatinine. Once we treat the hypothyroidism with thyroxine, this serum creatinine on its own will revert back to normal. There is also increased 24-hour urine protein, all of which tends to improve just from treating the hypothyroidism. How about GI discomfort? There is basically most important thing in GI is that there is reduced peristalsis leading to constipation, decreased gastric motility, and if they are already using one of these GLP-1 analogs, which is causing already the reduced gastric emptying, we might see that these patients come back with so much more bloating. So before we start a GLP-1, or if somebody is on the GLP and complaining of much GI discomfort, I usually make it a point to check the TFT. And it is also shown that there is some effect on the liver. In fact, as an aside, the newer medicine that is being tried for fatty liver is actually a derivative of thyroxine. So, which is, basically it works on the thyroxine receptors in the liver. So there are definitely crosstalk between the thyroxine and the liver. and we will not go into these details. So what about in young women? They tend to complain very early because they see that something has changed in their menstrual periods. They tend to come with polymenorrhea or menorrhagia, and even if they do not have anybody who has an infertility, is worth checking a TSH, a T4, and a serum prolactin. Remember that high prolactin in many cases is due to a hypothyroidism. Once we treat the thyroid hypothyroidism, prolactin levels come down to normal. In men, they tend not to complain too much, but in fact, this is proven that there is erectile dysfunction as well as reduced sperm count and motility and quality of the thyroxine of the sperm in men who have hypothyroidism. So anybody presenting with infertility also deserves a TFT. And of course, in pregnant women, it's very, very imperative that the growth and brain development of the baby depends so much on the thyroxine. Remember that some people are using T3, but T3 does not cross the placenta. So T4 needs to be used in pregnancy. And for the first 5 months, the baby does not have its own thyroxine. So it depends on the mother's thyroxine, and it also depends on the mother's iodine being transmitted through the placenta. So the first 4 or 5 months of pregnancy is the most critical time period for treating with thyroxine. And the time to check TFT is actually before they plan pregnancy. Get a normal TSH, ideally below 2.5 before the patient decides to get pregnant. So, and during pregnancy, they need to be monitored every month. And what about bones? This also might come as a surprise. We know that hyperthyroidism causes soft bones and osteoporosis, and hypothyroidism causes actually the bones might even be more dense on a bone density test, but actually the relative risk of fracture is actually at least 2 to 3 fold. And that's because the bone turnover does not happen and the bone reformation does not happen properly. So there is actually a higher risk even on the bones. So something we do not think about often, and patient never ever complains of bone issues, but then it's even important for for the bone health. So, and what about muscles? Patient doing a little bit of exercise in the gym and complains that he is not able to lift weights that he used to do before, and he does have muscles but is not strong. Remember that hypothyroidism causes muscle hypertrophy, but the muscle strength is so much less. They tend to get so much more muscle cramps, and they deserve a TFT. So with that, I would like to just like to pass on. Remember that memory deficits are probably the most important in young students who are going for exams. If they come for a checkup, I generally check a TFT just to make sure that there is no hypothyroidism. Because believe it or not, I had a patient whose father was a doctor who brought his son to my clinic just to get him checked because he had strong family history of thyroid disease, hypothyroidism. The son was a very good student, but his TSH was 800. I was shocked. Patient looked totally fine, but once he was treated with thyroxine, his complete behavior itself changed. So very, very difficult to pick up. As a practicing endocrinologist, I was surprised by the clinical presentation. Very, very difficult to pick up clinically. So check a TSH and free T4 whenever there is even the slightest of suspicion. Remember, it's most important for brain functioning. In fact, there is very good data that there is chronic inflammation of the brain and accelerated neural degeneration in patients who are low in thyroid. So, of course, it should not ever proceed to myxedema coma, but before that, we should check. And once we make the diagnosis, we should start treatment. And with that, I would like to pass on to the next speaker to talk about treatment of hypothyroidism. Thank you so much.
Thank you very much, Dr. Simon. That was an excellent and overview of the effect of hypothyroidism on different parts of the body. So thank you very much. And I think now it's time to hear from our second speaker, who's really a good friend of mine, Dr. Mohammed Hassanin, who's a senior consultant of endocrinology and diabetes at Dubai Hospital. He's well known in his research in endocrinology, especially in diabetes and Ramadan. So tonight he's going to enlighten us with a very important issue, that how we would differentiate between overt and subclinical hypothyroidism, and how to do we manage them? Do we manage them on the same, or does it mean different? So, Dr. Muhammad, the the mic is yours, and we are eager to hear from you. How do we manage such a common condition? Please.
Many thanks, Dr. Saud. It's a great pleasure to be with you tonight and with the audience. Thanks for the for Gate and for the sponsors to invite me. It's a great pleasure to be with everyone, and congratulations for the excellent attendance. I would have loved that this is face to face to meet with everyone, including the faculty. So let me share my presentation. Okay, so first here is my disclosure. Many of you would wonder, who is this person? Well, I come from Egypt, and this is one of the most beautiful queens of old Egypt, Nefertari. And she's known not just for her beauty, but for us as endocrinologists, because if you look hard, you will see that she has a goiter here as well. I can tell you that this is not just my opinion, but the opinion of many people who usually put this slide. So it's not just the imagination of endocrinologists. But thyroid problem is the second commonest problem that people see in primary care. Arthritis is the top, and then thyroid problems between hypothyroidism and thyroid nodules indeed are encountered in 21% of people going to primary care physicians. So focusing on hypothyroidism and the challenges of hypothyroidism treatment. Now, first, we need to remember and understand that the problem is increasing. I used to work in UK for 24 years, and this is data at the year I left, 2020, 2014. And as you can see, over the years, the number of people with thyroid problem, specifically with hypothyroidism across the UK, is being gradually increasing, and probably the curve is continuing to increase. Now, usually it's more of a problem that is related to gender, to female gender, and it's a problem also that occurs more as we get older. But there are other conditions that are certainly associated with hypothyroidism, primarily people who have other autoimmune conditions such as pernicious anemia, type 1 diabetes, rheumatoid arthritis, and lupus. And the issue of gender is very significant between the ages of 40 to 70 years, where you can see here in pink is females and in brown or gray is males. As we, in the younger age, as well as in the older age, the gap is a bit narrow. But certainly for the ages between 40 to 70, it's very much higher in female rather than in men. Now, when you look into the community and you look into people with a normal thyroid versus a subclinical clinical hypothyroid in black or in gray hypothyroidism, you will find the dilemma of thyroid subnormality is the symptoms are not usually there. So as you can see here, zero symptoms occur not just in people with euthyroidism, but also in the majority of people with subclinical or indeed with hypothyroidism. And those who have plenty of symptoms, 4 symptoms or more, are the minority. And it's not massively more than those who are euthyroid. So symptoms are not the best. And when you really think of the symptoms of hypothyroidism, you will really see they are very non-specific. And the previous presentation addressed issues related to the memory and so forth, because as you can see, they actually occur very frequently in people who are euthyroid as well. Yes, of course, it's a bit higher in people with elevated TSH. So we need to have a high level of suspicion when you see someone with dry skin, memory issues, slower thinking, weaker muscles, feeling more and more tired, muscle cramps, puffy eyes, the voice becomes deep, the constipation, and then the more severe levels of constipation and deeper voice, which are more rare and rare. So as you can see, when you look into the packages and the leaflets from thyroid associations, you will find a lot of information. Unfortunately, the social media are full of bad information as well as obviously good information. So it's very important to guide your patients to the right sources of information. But tiredness is one of the very common symptoms that people complain of, whether they have a thyroid problem or not. Now, why should we be concerned about a high TSH, a subclinical hypothyroidism, maybe not overt hypothyroidism? Because this is linked to atherosclerosis. When you look here into women with mild thyroid failure, or with women with mild thyroid failure, and on top of it, there is an increase in their or an elevated level of thyroid antibodies, you can clearly see that this is much higher than people who are either euthyroid or euthyroid but with positive antibodies. The antibodies does not increase the risk of illness or atherosclerosis. As you can see here, not different between the two. What is different is the presence of the high TSH with or without the antibodies. And again, here is when you look into the same issue of myocardial infarction or aortic atherosclerosis in a different study, that also in women of 1100 ladies, and blue is euthyroid, green is TSH above 4, and in that lab it was mild hypothyroidism. And again, you can see almost double the risk of myocardial infarction or aortic atherosclerosis in people with raised TSH. Certainly, the lipids level, the cholesterol level, is much higher as the TSH gets higher. And before you start someone with hypothyroidism on a statin, please correct the thyroxine level first to really have an accurate assessment of their actual lipids profile before you consider them as perhaps people with hyperlipidemia, which could be a reflection of just the abnormal TSH. Look into someone here with the TSH being quite high, as we see with many of those with overt hypothyroidism. Certainly, going above 10 increases the total cholesterol from a range of 5.6 to 6, and going even to 7 when you get into the significant hypothyroidism. What does the guidelines says? So I'm going to show you a mix between the American and the British guidelines throughout my presentation. So the point number 1B, what are clinical and biochemical goals of thyroxine replacement in a person with primary hypothyroidism? They consider three main goals. Number 1 is to resolution of the symptoms and signs of hypothyroidism. The person who's not feeling well, they need to feel well. Number 2 is obviously normalization of the thyroid function test. Number 3 is obviously to avoid overtreatment, i.e. iatrogenic thyrotoxicosis, specifically as people get older. And I mentioned that the thyroxine or hypothyroidism is frequent in people of the older generation. NICE guidelines are very good in this important point, which unfortunately I see in clinical practice frequently. If the thyroid antibodies are positive, then we do not need to repeat them. And certainly, we need to start treatment for subclinical hypothyroidism, taking into account the features that might suggest an underlying thyroid problem, as well as a person such as those with thyroid surgery or previous thyroid antibodies. So checking the thyroid antibodies might help you to strengthen your decision on thyroxine treatment in someone with a raised TSH. Definitely, you would consider thyroxine treatment in someone with a TSH above 10 or higher on 2 separate occasions, 3 months apart. And then you can consider starting treatment. If you start treatment, give it a trial of 6 months and then look into the normalization of the TSH as well as the symptoms of the individual. If the symptoms do not improve after starting thyroxine, then remeasure the TSH. And if the level remains raised, of course, we need to adjust the treatment. But if the symptom persists when serum TSH is within the normal range, then you have tried, you considered this was subclinical hypothyroidism, you started the treatment, the person is no better, then maybe we need to stop. Because at the end of the day, we are treating the person and not treating numbers. So how do you treat a hypothyroid and what would be the target TSH? How would you adjust the treatment increments and the frequency of follow-up, and whether this should be managed by specialist or primary care? So the NICE guidelines say that it's very important what I've mentioned before. TPO, once positive, always positive, and it's not a marker for activity. So if the TPO is positive, don't check it again. It's a waste of money, which is different than anti-TSH antibodies in people with Graves' disease. That's an issue for a different presentation. And again, remember, we are treating an individual. We're not treating a number. So the TSH is mildly raised. You've tried thyroxine. The person is no better. Stop the treatment after 6 months, because then you are not really treating the individual. Of course, this is important because there is a steady increase in the cost of prescribing. Approximately 15 to 20% of hypothyroid patients on thyroxine do feel tired. So you're not treating the symptoms, you're treating the person. And of course, the thyroid functions is an accurate resource or source for an assessment. So the great questions that we will ask ourselves really is, why should we achieve a euthyroid state, and is it important, and how do we achieve this and consistently? Of course, we need to offer thyroxine as a first-line treatment for adults and children and young people with primary hypothyroidism. We should not offer T3, liothyronine, for primary hypothyroidism, either alone or in combination with thyroxine, because there is not enough evidence to show that this is of benefit. And certainly we should not offer natural thyroid extract. I know some clinics in the region that are encouraging their patients to use these alternatives, but the evidence for this is pretty slim. And I'm sure, and this is copy and paste from the guidelines of NICE as well as the ATA. So follow-up and monitoring of the hypothyroidism. Of course, we need to aim for a normal TSH within the reference range of the lab that you're using. And obviously, we need to be aware that it takes up to 6 months to normalize. So don't rush it. It will take a bit of time to get the TSH down to the normal level. So aim to adjust the dose, and then within 6 months, this should be really achieved. Obviously, for adults on thyroxine treatment with hypothyroidism, it would be correct to measure the TSH every 3 months until they are stable, and then once they're stable, twice a year or once a year. Unfortunately, here we cannot, in governmental sector, give prescription more than 6 months. So that's the longest duration that you can allow without a follow-up. So after the initial dose, the patient should receive a repeat TSH measurement. Now, if the TSH is low, less than 0.5, then we should decrease the dose by 12.5 to 25 micrograms of thyroxine. Equally, if the TSH is above 4, we should do the same. Increase the dose by 12.5 to 25 micrograms per day. If it's within the normal range and the symptoms have resolved, then we should continue with the same dose and then remeasure after 6 months. So 3 months initially until you get to the right dose. Adjust up and down by 12.5 to 25 if we are within a small margin. If it's too high, of course, then you can increase the dose by a further amount than this. And be conscious that many people are either with inadequate thyroxine replacement in many studies, or they are over replaced. When you add this up, it is nearly 50% in some studies and a third in other studies. So between 30 to 50% are either over replaced or under replaced. And that thyroxine replacement needs a bit of careful measurement and careful talent to dig deep, specifically on adherence. Now, why this is important? Because low thyroxine or low TSH or high TSH has an impact on cardiovascular events, on dysrhythmia, on fractures, and of course, on mortality. So it's very important that we try to get it right, whether, because you can see here the lines of the suppressed, the lines of the low, the lines of the normal, and the lines of the heart and the high. And obviously we need to try to stick to the normal because it has the best outcome, of course, for people on thyroxine replacement. So what is a cause for inappropriate thyroxine dosage? Now, it could be something related to the doses. So poor compliance, inappropriate storage, the timing of the administration, the effect of food, the altered need for thyroxine in special populations, which will be covered shortly in the following presentation, gastrointestinal disease, switching between products. And yes, they might have accuracy, but for some reason, switching between products can cause alteration in the TSH and certainly impaired absorption of the drug. So the target TSH for a euthyroid state has to be individualized. And obviously this would depend on the age and the cause of hypothyroidism, other conditions and medication, food, pregnancy, cancer, lots of issues. In primary hypothyroidism, of course, we're aiming for a balance between biochemically euthyroid and, of course, as I mentioned before, elevating the symptoms. We need to use a standard high quality thyroxine product, and switching between brands to a generic may impact the TSH level, and because there is variation in the doses that could even be over 10% of the accuracy between one drug and the other. So in this particular important study, which was done in community pharmacy, they looked into, in Belgium, they looked into data of nearly 850 persons with hypothyroidism being treated with thyroxine for 2 years or longer, and they found that 25% had abnormal TSH, 28% were not adherent for 80% of the time, 73 days per year without taking thyroxine at all, and nearly 40% complied with ingesting the thyroxine for over 30 minutes before food. So many people need to have good education so that they can understand the ins and outs of thyroxine treatment and avoid the mismanagement because of the tablet. Now, the tablet itself, thyroxine, for its stability, would need to look into the excipients in it, the packaging, of avoiding the airtight, light-resistant containers, more than blister packs. The temperature, and the ideal temperature obviously is a good room temperature that is not too hot, 15 to 20 degrees, avoiding excessive humidity, avoiding oxidations, and of course avoiding the light. So it needs to be put in light-resistant containers. But very important point, and I've here highlighted it in red, well into the guidelines of the ATA, is how should thyroxine administration be timed in respect to meals and drinks in order to maintain maximum absorption. And the issue also of the competition with absorption with other medication. So co-administration of food with thyroxine is likely to impair the thyroxine absorption, and hence it should be taken 60 minutes before breakfast or at bedtime, which is, if you take it at bedtime, they mean here 3 or more hours after the evening meal for optimal, consistent absorption. So when we say to the person before breakfast, obviously before breakfast mean that they have been asleep, not eating or drinking, and then they take the tablet and then they wait for 60 minutes before breakfast, or they had their evening meal and it's 3 hours past the evening meal, then they take the tablet, and if they're hungry or they want to have another drink, they shouldn't be doing so for an hour. The absorption of thyroxine occurs in the jejunum and the ileum in an acidic pH in the stomach. And of course, we want to protect this as much as possible. 70 to 80% of the tablet is absorbed in the maximum circumstances. If we are to give food or drink apart from water with the thyroxine tablet, the absorption drops from 70 to 80% to about 64% or lower. So this is the cartoon that would explain this. If you take it on empty stomach without food, then it's 80% absorption. If you take it with food, that drops down to 64%. There's a difference of 16% but actually, if the bioavailable number is 80, then 16% over 80, that's nearly a quarter of the absorption. And interestingly, coffee does reduce the absorption of thyroxine and causes an increase in TSH. So don't take the tablet with a morning coffee saying there's no calories. It's not about calories, it's about the interaction with caffeine. So you take it with water. And in a study of nursing homes and people living in a nursing home, elderly, as I mentioned, they compared taking it in the morning at 9 a.m. and then waiting for 1 to 2 hours before breakfast, compared to at midnight, 3 hours after the last meal or after a snack, and the absorption was equal in both. So, very important, no food for 60 minutes. 60 minutes before and 20 minutes after, that's the minimum requirement. Consuming breakfast within 20 minutes after taking thyroxine resulted in a higher TSH compared with those who took it 60 minutes afterwards. And I think this cartoon of Tom and Jerry describe it. If you touch the food within 60 minutes, you will be hammered. I hope that is not the reality. It's just a comedy cartoon. But don't forget the interaction with many drugs that we frequently prescribe. Calcium tablets. Many of the patients with thyroxine replacement had thyroidectomy, and some of them had parathyroidectomy as well. So they are on calcium tablets. So there is an interaction between the two. Many are anemic and on iron. And of course, some are on drugs such as the aluminium containing antacid or sucralfate. Many people have gastritis and take these medications. Now, Ramadan. Just a quick point about Ramadan. We said you take the tablet on empty stomach. Okay, that could be at iftar time. But is it really realistic after fasting for 15 hours to wait for an hour? What happens is we are hungry, we want to take our vemto, our juice, our tamr, and so on. And that's not easy to do at all. So when you think about it, we fast from Fajr until Maghrib, and then from Maghrib until the following Fajr is usually about 9 hours. So fasting for 15 hours it's not easy for people to delay it for an hour, another extra hour. That's quite difficult. Now, during the eating hours, many people are snacking, and taking thyroxine at suhoor is a possibility, but obviously you need to delay for food for another hour. So you need to be awake, take the tablet, no food for the previous 3 hours, and then wait for 1 hour. So in Ramadan, it's a dilemma on when is the best time. Again, it's a reminder. If the person is able to take it at iftar and to pray and maybe use plenty of time for the prayers and wait for the hour, perfect, or at least half an hour. If they're not, then we need to find a window after the main meal, after iftar, with 3 hours later, and to consider asking the person not to eat afterwards. So that's an option after Taraweeh, perhaps at 10 p.m., and ask the person not to eat anything. Maybe they're not too hungry at the time, so that would be a possibility. So this is the prayer time a couple of years ago, and it hasn't really changed massively between the usual Ramadans. So what not to do is to what you don't want to do is to forget taking the tablet, because if you take it with food, the absorption is 64%. If you don't take it, the absorption is 0%. So you need to take the tablet, okay? Even with food. And maybe even one pragmatic approach is just increase the dose in Ramadan by 20% or 12.5 micrograms, as we mentioned earlier. Perhaps half a tablet of the 25 would do the job, or 25 micrograms on alternate days, and extra in a person who's taking 100 micrograms on a daily basis. So in summary, ladies and gentlemen, achieving euthyroid state is important to reduce potential of serious conditions. Individualized approach is really required. Non-adherence is common cause of not achieving euthyroidism. Standard high-quality levothyroxine preparations should be used, and switching between products is not recommended and is much to be avoided. Thank you, and I'll leave you with a photo of Alexandria, my beloved city. Thank you very much.
Thank you very much, Dr. Muhammad. That was an excellent. So I think now we would move with our speaker. Again, we are going to talk about a very important topic in which how do we manage a special population like those who are elderly, cardiovascular disease, pregnant ladies, and I think you're going to enjoy this. So our speaker is Dr. Hamad Hussein, who's an staff physician in endocrinology department at Cleveland Clinic at Abu Dhabi, where he had been doing with his endocrinology practice. So, Dr. Hussein, we are very eager to hear from you. How do we manage those special populations? Please.
All right. Good evening. Thank you for the invitation. Thank you to the sponsors, and thank you to the attendees for attending at this time. So let me just share my screen. So good evening, everyone. I'll do a brief introduction. So I'll talk about a little bit about what has already been discussed, but just to re-emphasize, I'll talk a little bit about hypothyroidism, thyroid replacement, and how it becomes important with some concurrent medications, because I think that's very important, because most of our patients may be taking more than one medicine, especially as they get older. I will talk about thyroid replacement in pregnancy, which is a very important topic. I will discuss also about thyroid replacement in the elderly, which has been touched upon, and I will just re-emphasize some of the points. And I think Doctor has really nicely, Dr. Hasnan has talked about thyroid hormone in Ramadan. I have a couple of slides at the end just to overview that as well. So just some of the things that we have already discussed about. It's a most common endocrine disease, primary hypothyroidism. Prevalence is about 3.8 to 4.6%. Annual incidence in women is 4.1 per to 1,000 and 0.6 per 1,000 in men. And levothyroxine is one of the most prescribed, highly prescribed medication, at least in the US, after statins and aspirin. Diagnosis ideally should be simple, but as we know that sometimes there are the labs and the symptoms do not go together and they may be confusing, and so could the management be challenging. The problems that we face with hypothyroidism management could be under replacement, over replacement, or the patient just not feeling well despite of normal thyroid levels. I think we've all come across those patients. So the causes, we have discussed this already, but this is just a brief overview. We split hypothyroidism into primary versus secondary. Primary is the problem with the actual thyroid gland. It could be autoimmune. The most common is Hashimoto's. Or it could be the patient has undergone radioactive iodine treatment or has had external radiation or drugs and we'll talk about those, certain medications such as amiodarone, lithium, certain antithyroid medications, and also the newer tyrosine kinase inhibitors. They can also cause destructive thyroiditis. The primary causes can also include congenital hypothyroidism, iodine deficiency, and certain infiltrative causes such as amyloidosis, sarcoidosis, hemochromatosis, scleroderma. And in the very, very young, we have seen overexpression of the enzyme that breaks down thyroid hormone, the type 3 deiodinase, especially if we have seen liver hemangiomas carrying these enzymes that actually causes destruction of the thyroid hormone. Secondary causes is when the defect happens at the level of the pituitary. So we have pituitary tumors, or someone who has undergone brain or irradiation or pituitary surgery, hemorrhage of the pituitary after trauma, or in women after pregnancy. They can present with something called Sheehan syndrome, which is the hemorrhage of the pituitary gland causing secondary hypothyroidism. Isolated TSH deficiency has been identified, and this agent called bexarotene, which is sometimes used in T cell lymphomas, can actually cause thyroid hormone dysfunction. There can be also hypothalamic diseases such as tumors of the brain, trauma, or metastatic infiltration of the hypothalamus, because as we saw on the earlier slide, the stimulus comes from the TRH comes from the hypothalamus, then goes to the pituitary, which makes the TSH. As we have already learned that the diagnosis is can be challenging at times. The sensitivity of the individual symptoms, according to this study that we have previously referred to, the sensitivity of the individual symptoms can be anywhere between 2.9 up to 24%. The likelihood increases the more symptoms of hypothyroidism that the patient has, such as cold intolerance, weight gain, fatigue. Absence of symptoms does not exclude diagnosis, but unfortunately, symptoms are non-specific. We can see sometimes hypo symptoms occurring in patients who are euthyroid. So diagnosis is not only symptomatic, but most importantly, diagnosis is biochemical. Overt primary hypothyroidism, as we discussed, is when the TSH is above the reference range and the T4 is low. Subclinical is when the TSH is high, but the free T4 is normal. 95% of healthy individuals actually have a TSH less than 2.5. In pregnancy, which I'll go over, we should ideally use trimester-specific ranges, but unfortunately, most of the laboratories that we use do not provide us with trimester-specific ranges for the TSH. So we have to rely on just the ranges that are available for normal population. There's certain genetic conditions that can also cause the TSH reference range to be different, but fortunately, these are rare. So one thing which we have to, which I just put a slide there because I think it's important, because some of our patients are using amiodarone, or some of them actually get a huge load of iodine through an IV contrast. So IV contrast contains a lot of iodine, sometimes as much as what the recommended daily allowance of iodine is for the whole year, they can get in one IV contrast, which has iodine. So iodine can both inhibit thyroid hormone synthesis, and it can also cause hyperthyroidism. So someone who has recently has an iodinated contrast, they come with symptoms of hyper or hypothyroidism. That's something which we should be thinking about. It is more common in patients who already have an autoimmune thyroid disease, and then they get an iodine load, and that can cause hyperthyroidism. So something to be careful about. Amiodarone, a lot of our patients with heart disease can be on amiodarone. One tablet of amiodarone contains 7 milligrams of iodine per 200 milligram tablet. That's about 45 times the requirement of iodine per day. So our daily requirement of iodine is 150 micrograms, whereas one tablet of amiodarone has 7 milligrams of iodine. So quite a lot of iodine. And amiodarone can not only cause hypothyroidism, if it in an iodine sufficient area, it can cause hypothyroidism, but it can also cause hyperthyroidism as well. So there are two different kinds of amiodarone-induced hyperthyroidism. I will not go into that, but just to keep in mind that amiodarone can cause both hypo and hyperthyroidism, and so can lithium. Lithium can also cause. I just saw a patient today who is on lithium, and she came in with sudden onset of hyperthyroidism. Although the lithium she has been using is for a long time, but it can cause a thyroiditis kind of a picture. So I've worked her up for hyperthyroidism and autoimmune thyroid disease as well. Medications are very important. I think we've already gone over that. So there are certain medications that decrease the conversion of T4 to D3. So like amiodarone, not only can it cause hypo or hyperthyroidism, it also decreases conversion of T4 to T3 as well. Steroids or propranolol can also do that. So some of these patients who are on concurrent medications, sometimes we may have to increase the dose of their thyroid hormone. There are certain medications that can cause a glucuronidation of the thyroid hormone, and we may need to increase the dose of thyroid hormone if they're concurrently using phenobarbital or phenytoin or carbamazepine. You may have seen recently TKIs or tyrosine kinase inhibitors being used for different cancers. I think sunitinib is the first one that was identified causing thyroid disease. So patients who are already taking levothyroxine, we may have to increase the dose of the thyroid hormone because they do increase the enzyme activity of the type 3 deiodinase, which causes degradation of the thyroid hormone. Sunitinib, I think, was first introduced many years ago for renal cancer first. And also bile acid sequestrants, sometimes we use them for cholesterol treatment. They also decrease in enterohepatic circulation of thyroid hormone, and therefore the thyroid hormone requirement may increase. I put this diagram in because I find it very useful because about 10 to 20% of thyroid hormone is absorbed in the stomach, and about 70 to 80% is absorbed in the upper intestine, jejunum and ileum. So conditions that can affect the stomach or the ileum, like celiac disease, lactose intolerance in the ileum or the jejunum, or H. pylori or gastritis or enteritis, or any motility disorders can actually affect the absorption of thyroid hormone. So if someone is on thyroid hormone and requiring a higher dose, you have to think about, do they have a concurrent condition that is affecting the absorption of levothyroxine? I just put this table in because it just goes over medications like PPIs, calcium, which we've already talked about, causing decreased absorption at the stomach level. And there are certain medications like iron or certain coffee we talked about, or grape juice, soy supplements. It inhibit the absorption at the intestinal level. And there are certain medications or milk or sucralfate or aluminum hydroxide that affects the absorption, both the gastric and the intestinal levels. So someone on levothyroxine on concurrently these medications and their thyroid levels is just not getting under control, we have to think about, do they take any medications which can cause a decreased absorption or interference of the thyroid medicine? So there was a large study with almost 11,000 patients, mostly females. TSH was periodically checked, and they noticed that iron, calcium, PPIs, estrogen use, they all caused high TSH levels despite of taking levothyroxine. Statins, interestingly, caused low TSH levels, and there are a couple of hypotheses why statins can cause low TSH. But they said that maybe by lowering the LDL, statins improve the membrane lipid composition and enhance tissue sensitivity to the thyroid hormone, which could lead to reduced TSH secretion, and maybe that is why the TSH is low in these individuals. We already discussed this, but iron, calcium, aluminum, sucralfate, bile acid sequestrant should be at least 4 hours after levothyroxine. Soy, milk, coffee should and breakfast should be at least 30 minutes to 60 minutes after taking levothyroxine. Causes of persistently elevated TSH, we've already discussed. Inadequate thyroid dose, poor compliance, it's very important. Interaction with other medications like we discussed, malabsorption, and always keep in mind lactose intolerance. Do they have gastritis? Do they have celiac disease? And very rarely, sometimes when we have high TSH and we keep increasing the levothyroxine dose, those patients may have something called thyroid hormone resistance, which means there's enough thyroid hormone in the body, but it's just not enough. The body the pituitary is not responding, and the pituitary gland just keeps making TSH because the receptors that work that T4 attaches to, they're not sensitive enough to the thyroid hormone. So in those situations, I think getting an endocrinologist involved is helpful. So we've already talked about this, but initial good doses could be 1.4 to 1.6 microgram per kilogram for an otherwise normal patient. For pregnancy, we'll talk about that. We have a whole discussion on that in the next few slides. For elderly, we always start with a lower dose. Again, I have a couple of slides for that. Patients with heart disease, we we tend to start at a lower than calculated dose. But for most other individuals, 1.4 to 1.6 micrograms per kilogram per day. One important thing is sometimes we see patients with thyroid cancer on a higher dose of levothyroxine, especially intermediate or high risk thyroid cancer patients. So if you see those patients, please do not adjust the medications without discussing with an endocrinologist, because we may want to keep the thyroid level slightly high to prevent recurrence of thyroid cancer in those individuals. We talked about poor compliance already, so I'll skip that. So thyroid in pregnancy, I think it's very important. Most important common thyroid disorder in pregnancy is hypothyroidism, and subclinical hypothyroidism is also very common. It's defined as TSH above the upper limit with a normal free T4, like we've discussed, just like in a non-pregnant individual. If we don't have an overt hypothyroidism is defined as TSH above the normal range with a free T4, which is below the normal range. So that's overt and subclinical hypothyroidism, just like the definition for a normal non-pregnant individual. Isolated hypothyroxanemia is sometimes we have normal TSH with low free T4. Those individuals, there has been a lot of debate about them, and we don't generally need to treat them. And I'll discuss that in just the next few slides. When available, we should use a trimester-specific reference range for those pregnant patients. If we don't have a reference range for pregnancy available, generally what we do tend to do is we try to lower whatever reference range is available. The lower limit, just decrease it by 0.4, the upper limit, decrease it by 0.5, and it will give you a rough idea of what should a reference range be for at least in the first trimester during pregnancy. Ideally, we should have a reference range for pregnancy, but if not, that's what we can do. Usually, free T4 is not reliable during pregnancy, and I'll tell you why in just in the next slide. So we use a total T4 is another test that we can do. If TSH is a good test, but in case we want to see some immediate changes in the thyroid hormone adjustment, we can use a total T4. And generally, the total T4, also the reference range, is higher than a normal non-pregnant individual. Generally, the reference range for total T4 goes up by 5% per week, starting at week 7. And at week 16, if the patient comes in at week 16, we should use 1.5 times the normal range for a non-pregnant individual. So TSH, we decrease the dose by we decrease the reference range by 0.4 and 0.5, and total T4, if we are checking it, we should increase the reference range by about 50% or 1.5 times normal. So let's say this is an example of a 30-year-old female patient, 12 weeks of pregnancy. She's fatigued. TSH is 4. Total T4 sum has been checked already, and it's 12. So the TSH is on the upper side of normal, just exactly at the border of normal when the normal range is 4, and the total T4 is just at the borderline low side of normal. So what is the diagnosis? Should she receive levothyroxine? And if yes, what dose? So like I said, once we adjust the dose for the TSH and the total T4, it comes to that she's just borderline subclinical hypothyroidism, because we have adjusted the reference range for a pregnant patient. So we have decreased the TSH. So instead of a 4.2 or 4.4 for a normal individual, for a pregnant individual, the reference range the upper limit will be 4. So following that reference range, the patient will be subclinically hypothyroid. It's a little debatable. The patient did have thyroid peroxidase positive antibodies. So what would we do in this situation? I did start this patient on 50 micrograms of levothyroxine, and I adjusted her dose, and I'm checking her dose in the first trimester every 4 to 6 weeks. There's weak evidence for this. If we decide not to treat this level of subclinical hypothyroidism, at least we should remeasure every 4 weeks during the first trimester to see what is the progression of the thyroid. If they're overtly hypothyroid, there's no question we should treat them. But this is sort of subclinical. And at the last slide, I will actually go over what do the guidelines recommend. So what happens to thyroid hormone during pregnancy? The HCGs during the first part of pregnancy actually can stimulate the thyroid gland, and temporarily it can cause low TSH and high free T4. So that's very important to remember. If you see a patient in the first part of pregnancy and the TSH is low, it just may be normal physiology. We don't have to jump on treating that patient. So low TSH, high free T4 can be seen because of the HCG effect. The thyroid binding globulin also increases, so that causes high total T4 and total T3, and that is why I spoke about increasing the reference range by 50% during pregnancy, because the TBG is high, and therefore the total T4 and total T3 levels are high. There's high increased urine iodine excretion during pregnancy because of the placental deiodinase enzyme. There's higher degradation of T4 to T3. And usually during pregnancy, the thyroid peroxidase antibodies will come down. There's some immunological changes. So we do expect that in patients who have Hashimoto's, that TPO levels come down. Just goes over a graph. So as you can see, as the HCG goes up, we do see a little bit of decrease in TSH levels during the early part of pregnancy. And we do see, as we discussed before, the total T4 and the total T3 going up because of the TBG. They may keep going up until the week 16 of pregnancy, and then they plateau after that. So I'll skip the part about the placental transport of thyroid hormone, but one important thing that we have discussed even before is T4 is observed in embryonic circulation at 4 weeks post-implantation, and fetal thyroid hormone gland begins to concentrate iodine and starts synthesizing thyroid hormone at weeks 10 to 12. So until week 10 to 12, the fetus is completely dependent on the mother's thyroid. And therefore, if the mother is hypothyroid and already on levothyroxine, the dose of the levothyroxine needs to be increased as soon as the mother confirms that they're hypothyroid. Because I'll go with the next slide. It is very important that we start treatment as soon as, or increase the dose of levothyroxine as soon as the treatment pregnancy is confirmed. There have been some studies that show should we start treatment for subclinical hypothyroidism even if the thyroid peroxidase antibodies are high, like the example I gave you in the beginning. But those studies, especially the more common, the more famous ones, for example, by Dr. Casey, and that was in NEJM in 2017. In those situations, the thyroid hormone supplementation started at week 16. So it was already, I think, a little late to start leave, and they did not see any benefit in the cognitive function of the baby after born at when they're 4 or 5 years old. But that is probably because the treatment was started a little bit later. If they had started earlier, the levothyroxine supplementation, maybe they may have seen benefit. So this again goes over the same thing, that the fetus thyroid does not start functioning until week 16, or sorry, by week 8 to 10. And until then, the fetus is dependent. The hypothalamus, hippocampus, sexual differentiation. So it's very important to start early treatment. Should we treat subclinical hypothyroidism? Like I discussed before, retrospective studies suggested slightly decreased IQ in patients who are subclinically hypothyroid in those offsprings. Overt hypothyroidism, definitely we need to treat. Subclinical hypothyroidism, they have seen early miscarriage and preterm delivery in some, but not all studies. Should we treat, I saw one of the questions, treatment of TPO positive alone when the thyroid level is normal? There's no benefit. But yes, so if the TSH is normal, but the TPO is high, we don't have to treat it. But I think it's very important to continue to monitor those patients very closely. There are 2 randomized controlled trials that show the TSH 4 to 6 with no clear benefit. But like I said in the previous slide, in those trials, the treatment started at 14 to 16 weeks. So maybe the treatment started a little bit late anyway. So if they had started early, maybe they would have seen some benefit. So in summary, TSH10 in pregnancy with subclinical hypothyroidism, treat. 4 to 10 with positive TPO, most would treat. The newer guidelines that are coming out for thyroid and pregnancy, they probably will suggest that timing of starting treatment is more important than actual number. So the earlier we start, the better benefit, the more benefits we'll see. 4 to 10 negative TPO, most will still treat. And when we start treatment, the goal is to keep the TSH below 2.5. And we monitor every 4 to 6 weeks until week 20, and then at least once every trimester after that. I will skip this part, and then how I think the screening is very important, because that's also something which is going to change in the new guidelines. We used to screen everyone above age 30 and having 2 prior pregnancies or morbid obesity. So that has been listed as not any more clinically meaningful. What is meaningful now is to make sure that if they have a history of subclinical hyper, postpartum thyroiditis, or known thyroid antibodies, those are the patients you should treat, as you should screen them for hypothyroidism as soon as they confirm pregnancy. I will skip this part, but I think the important thing to remember, which has been discussed before, is sometimes we see liothyronine or T3 being used as soon as someone mentions to you that they have plans to get pregnant, I think it's very important to stop the T3 because it does not cross the placenta. It may and it may actually cause the TSH suppression, maternal TSH suppression. So I think it's very important to stop the T3. And there are different methods to calculate how you can, if they are on a combination of T4 and T3, how to convert them from T4 to T3 to just T4, which is the levothyroxine. So once pregnancy is confirmed, usually if they're already on levothyroxine, we increase their dose by 30%. A practical way of doing that is to tell the patient to take 2 extra tablets per week and remeasure thyroid after TSH after 4 weeks. Adjust dose to keep the TSH less than 2.5 in the first trimester and less than 3 thereafter. And after delivery, you can return to the pre-pregnancy dose and then recheck a thyroid level after 4 weeks. I will quickly go over the next 2, 3 slides, which because we've already touched on that. Thyroid in older individuals with advancing age, the clearance of circulating T4 does decrease, and there's also already a compensatory reduction in T4 and T3 production with age. Prevalence of thyroid antibodies also increases with age, particularly in women. And older individuals may not have the classic symptoms of hypothyroidism that the young individuals have. When you see these older individuals, actually we see a lot of them who have levothyroxine prescribed, and the proportion of adults who report levothyroxine use has also increased over the last few years, maybe because of more testing. There is also a rise in levothyroxine initiation for subclinical hypothyroid patients. So they may not need to be treated to begin with, but they're already on treatment when you see them. And once levothyroxine is initiated, unfortunately, then no one thinks about discontinuing them and they continue it lifelong, even if it's not needed to begin with. So overt hypothyroidism should be treated obviously regardless of age, but transient mild fluctuations of TSH may occur in older individuals. So if you see an individual who's above 65 or 70 and they have high TSH level, I think and normal free T4 and T3, it's a good idea to wait for a few weeks and recheck it. And I will go over at what level we should start treatment in those individuals. So older adults who have TSH above 10 and normal free T4 should be initiated on levothyroxine, but maybe at a lower dose. Consider initiating treatment if TSH is 7 to 9.9, and that's based on observational data that it may help these individuals. And older individuals require usually 20 to 25% less per kilogram body weight dose than the younger individuals because they have lower body mass and they have lower decreased metabolic clearance. And the important thing is start low and go slow. 1.1 microgram per kilogram may be a good, or 50 microgram per day may be a good dose. TSH goal, we don't have to normalize TSH. Anywhere between 4 to 6 TSH is normal if they're already on levothyroxine. You don't have to make the TSH normal. 4 to 6 is a good range. There was a large study that showed that adults more than 65 years of age who are prescribed levothyroxine, 1/3 of them are on concomitant medications that interfere with levothyroxine absorption, the ones we discussed before. So please make sure that you counsel them on when to take those medications and how to space them out so that the levothyroxine is absorbed properly. And we have to avoid over treatment or over replacement in older individuals, like in any individual, but especially in older individuals, because it can cause atrial fibrillation, cardiovascular risks, fractures, and under replacement can also cause mortality and dementia and cognitive impairment. So try to aim for 4 to 6 TSH target. We've already talked about this. This is the last slide that I have. I actually just made like a summary chart for the last 4 or 5 years of levothyroxine administration in Ramadan, when is the best time to take them. But in summary, if we summarize this slide, we do see that TSH does rise during and after Ramadan in patients who are already on levothyroxine. So always check a thyroid level post Ramadan because it may be abnormal. As previously we discussed in the previous talk, there's no good time that has been decided. Pre-iftar dosing, like 30 minutes before actually eating, is probably the best way to take levothyroxine. Another way to take it, according to the study, is adding a 25 microgram extra dose during Ramadan that may help maintain euthyroidism in certain individuals. And ultimately, the important thing is adherence is more important than exact timing. Exactly like we discussed in the previous talk, tailor and advise the patients what is they can realistically follow. So talk to the patients when they think is the best time they can take levothyroxine. So in summary, we discuss hypothyroidism, what are the concurrent medications that can affect absorption, hypothyroidism and treatment in pregnancy and the older individuals, and how to treat hypothyroidism in Ramadan. Thank you very much for your attention.
Thank you very much, Dr. Hussein. That was really an excellent overview of hypothyroidism in those very special and delicate populations. So thank you very much. I think it was wonderful. Now we would go into our sponsored satellite symposium, where it is going to be given by Dr. Simon, where we wanted to hear about the precision in euthyroid state. So please, Dr. Simon.
Just wanted to get to the nitty-gritty of using thyroxine in clinical practice. It seems like a very, very simple medication to use, but there are certain practical issues that we should be aware of, and we generally tend to ignore that, but this actually tends to be quite important. Why? Because it is, in fact, is one of the top 10 most widely prescribed medications worldwide. But in spite of that, there is a big problem because it has a very narrow therapeutic index. The dose has to be kept kind of constant. The patients are usually, like 90% of the time, they are on lifelong treatment with most Hashimoto's cases. And there are several interfering factors, And of course, we know that people who have, other medications being taken along with it, of course, the timing of taking it, like Ramadan, people who are on, different kind of diets, and also a lot of patients who are now had, bariatric surgery, sleeve surgery, gastric bypass, all of them tends to affect the absorption of these medications. Of course, not to mention how good the patients are in complying to medication. In fact, WHO says the average compliance for most chronic medications is about 50%. In fact, thyroxine has a better compliance than most other regular chronic medications, but still, in real life utilization of this so-called easy to use hormone has a lot of potential problems, and the magnitude is significantly increased because at least 5% of the general population at some point is on thyroxine. And of course, we will not talk about the T3 combinations. When I was practicing in the US, it was a daily discussion with the patients that, doctor, how about I use desiccated thyroxine or armor thyroid, or what about I use seaweed and kelp instead? So fortunately, I do not have to deal with this issue too much in Abu Dhabi. I'm not sure about all your clinical practice, but this is a regular discussion that used to happen. Once in a while, I still have to have this. But basically, T4 is the standard of care, not T3, mainly because it's a long-acting medication. T4 has a half-life of 7 days. T3 has a half-life of only 1 day. And even in patients who have had a thyroid removed, the deiodinases are still working, and the T4 gets systematically converted into T3 and leaving a very nice steady state. So it's a very nice medication to use. Only problem is, it comes in a tablet form, which is not really very well absorbed unless we take care of the other medications that is going with it. Some patients are taking PPIs, which can affect the absorption. Some are taking, medications for osteoporosis, which can also be a problem because they all need to be taken on empty stomach. But remember that the tablets comes with, a lot of excipients. Some of them can also have an effect on how the medication is absorbed. Now, the tablets really, it comes as a tablet. If we crush it, the absorption gets better. Now we have liquids which are having a slightly better absorption. In fact, when they use the liquid form, the TSS tends to be a little bit lower, but it's really not very significant. There is also the newer formulations, which is gel form, which also the studies did not really show a major advantage for either of these except in very rare patients who have difficulty swallowing, who can take it, with water. Of course, there are also patients there are also thyroxine injectables, which we use only, patients who are in the ICU, who have, say myxedema coma or something. So this is a standard. There's a statement from the joint European Thyroid Association and Thyroid Federation International, which says that try to stick to the same brand, because even if we change from one medicine to the other, both of them having the same strength, let's say 100 microgram, it does not really guarantee continued euthyroidism, though it's bioequivalent. So, and the reason is because between the brands, there is a significant difference in change. So if at all possible, I tell the patient, tell the pharmacist, please do not change it from one medicine to the other. Stick to one brand if possible, as much as possible. Mainly also because the cost is not really that different. And if you look at the global phenomenon, I mean, we see that it's one of the most frequently recalled products from the market, mainly because it is not maintaining potency. If we look at one brand versus the other, or even the same brand, if you look at one lot number versus the other, there is actually oftentimes a significant difference. Of course, the storage inside the pharmacy and in the patient's home is also quite important. If it is exposed to heat, if it is exposed to even light, there is actually a degradation over time. Even in the same brand, properly stored can have, over time, there is a reduction in the bioequivalence. So now the FDA has actually, restricted the multiple generics, and they've said that you must maintain a potency range of plus or minus 5%. So if it is saying 100 microgram, it should have 95 to 105. It's not allowed to be more or less than that. So it is actually a good thing for the patients. And this has forced the pharma companies to actually improve the formulation. And the good companies have actually improved the formulation so that this takes care of better stability for the pharmaceutical product. This is not just in US, even in France and UK, they do require this, plus or minus 5% bioequivalence requirement. So just wanted to show that, other than the active ingredient, there is also some other things that are added to increase the stability of the medication, which now we have up to a 3-year shelf life, which is much better than what it used to be. I remember when I was young, my mother was on thyroxine, and it used to come in this, kind of transparent bottles, not fully opaque. And it was obviously not ideal. And later on, they changed to plastic bottles. And even that, every time you open it, there is, the change in hydration. So that is also not ideal. And nowadays we have blister pack with each tablet coming in a separate blister, which is definitely much better, which is opaque on both sides. So the new formulation I'm talking about the commonest brand that we see here is Euthyrox. It has actually, they now changed from lactose to mannitol to increase the stability, and also there is enhanced stability due to citric acid. So in most regular patients, it may not make much of a difference, but in those we are trying to maintain a very strict therapeutic window, especially those like thyroid cancer patients, or those who are pregnant women, and also young children and elderly, or somebody who is always having very much variable TFTs. So these are the people for whom these practical points might be important. Tell them, please stick to the same brand, a good brand as much as possible. And since it is not really very expensive, it's almost not really worth it to switch to a generic, because the pharmacies might keep changing from one generic to the other according to insurance coverage and according to formulary regulations. So the newer ones have same benefits as the older formulation. It's actually bioequivalent, and this is the study which looked at the newer versus the older. You can see that the bioequivalence is exactly the same. It's just that the stability is for a much longer period, up to 3 years, stable on the shelf. So we have, right now 25 to 150. I don't know if we have any of you have access to 75 microgram. I do not have 75 microgram. I've never seen it in last several years. That is a big deficit. Of course, in many countries, I mean, when I was in US, you could get uh, uh, doses as, you could get 75, you could get 88, you could get 100, you could get 112. Unfortunately, those strengths are not easily available in this country. So that is something that is we are still facing as practicing physicians. But with that, I mean, I'd like to thank you so much for being here. I just would be happy to take any questions, and I would.
Thank you very much, Dr. Simon. That was excellent. So thank you. I think we had really a very good night where we have been talking about hypothyroidism. We have seen the different scenarios that we might face, and always the message that we get from here that it's always an important to keep an open eye for all of those. So always you have to suspect in order to treat. So thank you very much. I've got more than 600 attendees with more than 100 questions. So you could see how much there. I'll just ask my other colleagues, Dr. Muhammad, Dr. Hussein, to join me, and I would request one thing that I would need as quick as possible answer in order to get many of those questions. So we've got another 15 minutes. So in that, we would try to see how much we can. Now, this is a common question because I've been trying to put them all together. In most of these questions that they are faced with patients who has got TSH more than 10, but always their T4 and T3 are normal. How do we deal with this case? So anyone of faculty can start very quick so that we can take the other one.
I can would recommend that TSH above 10 is an indication for initiation of treatment. And as I mentioned in my presentation, after adjust the dose, and then within 6 months, if symptoms have gone,
You mean 6 weeks?
in 6 months. So of course, adjustment of the dose over 6 months. By the end of 6 months, rethink if the patient TSH is normalized and he feels well, perfect, carry on. If not, then don't just treat the number, treat the person.
Okay, thank you. Do we need to repeat TSH if it is above 10 in patients who are
Sure. I mean, every
And how-
6 to 3 months, you would adjust the dose by 12.5 micrograms to 25 micrograms if it's still raised. And then within 6 months, what I'm saying is by the end of 6 months, we should have reached a euthyroid status. But if the person is still symptomatic and feeling unwell, then there's no point.
Okay. Again, questions related to autoantibodies. So what is the role of anti-TPO in those, and do we have to request them in people with hypothyroidism? Please, Dr. Simon or Dr. Hussein? Yeah, Dr. Simon.
Yes, generally, because 90% of all hypothyroid disease actually autoimmune in this part of the world. So it's good to know the etiology. So I always do measure the TPO at least the first time, because we know that it tends to remain. It does not disappear. Sometimes it tends to pop up. Sometimes when you use tyrosine kinase inhibitors, a negative TPO patient might turn into a positive one. But once it is there, it tends to remain. So it's nice to make a diagnosis, especially in patients who are pregnant and all. It makes a big difference as to whether you would like to treat. If there is antibodies are high in subclinical or in pregnancy, definitely there will be one more indication to maybe be more aggressive with treatment.
Okay, as a continuation to this, if thyroid function tests are normal and anti-TPO titer is high, should we initiate a small dose of thyroxine? This is again another question.
No, I can take that. There's no evidence that treating a euthyroid patient with anti-TPO positive will be beneficial. The only thing we can do is we just monitor them a little bit more closely if they have TPO antibody positive. But if they're euthyroid, there's no benefit of starting them on levothyroxine.
Okay. Here again, decreasing the RAS activity. Is it beneficial in people with hypothyroidism?
Not really, no. There's no point to look into it too much. You have clear parameters of treatment of hypothyroidism, a high TSH and a low T4, but other things are, I mean, especially RAS is not really a big issue.
Okay. Here again, Dr. Sen, now, can thyroid supplement be given once a week? This is a very trip question.
Um, I can take that, although
Okay.
so it's a little controversial. Yes, so I have actually personally I have also used it once a week. IM levothyroxine for very few individuals who are just on very high doses of levothyroxine and we're just not able to get them euthyroid or under control. And there may be an underlying cause. They have very poor absorption of thyroid because of multiple gastric surgeries. So I do use it, but we have to be careful if we use it. It's once a week or once or twice a week. We have to, in younger individuals we can, but if they have cardiovascular disease, then we have to be very careful about using them. So yes, it can be used, but and also availability of IM levothyroxine sometimes is very sketchy. So we get them sometimes it's not available. So I've had a few patients, but it's just very few who, if we've ruled out everything else, then that's an option which is available.
Okay, so we use it only in a very few cases, which is individualized. Okay, now again, Dr. Simon here, if TSH is between 5 and 7, mildly elevated with the normal T4 and T3, should we take thyroxine, and how much thyroxine should we take if we decide?
I think Professor Hasanain would be the expert in this.
Yeah, I
But
mean,
generally,
thank you.
Okay.
Thank you. As I mentioned in my presentation, if the TSH is mildly raised, and then you need to look into two other factors, either the antibodies or the symptoms. So if one of them is present, then you have enough reason to think or to give it a therapeutic trial and then to reassess within 6 months. But if the person is asymptomatic and antibodies are negative, then I would just monitor, considering that this person might be slowly cooking a hypothyroidism over the next months or years. And sometimes it takes years to change it all.
All right.
I would
Now,
like to add that unless somebody is planning to get pregnant, in which case you would
okay.
be.
Yeah.
Excellent. Now, again, here, if people are having, let's say, vague symptoms, general vague symptoms, do we need to screen them for hypothyroid? Please, Dr. Sim.
Yeah, I must say that most people who get diagnosed with hypothyroidism initially present with vague symptoms. So, yeah, I think probably if I had to pick one test to do in every patient who comes in with vague symptoms, it's the TSH.
Okay. Now, why we don't have a dose of 12.5 of thyroxine? Why only we are having doses which is
There
like
are, I mean, if you
500?
go to the US, there is
Yes,
about
but I mean in the
10
region, in
different
our Gulf
doses.
region. In the Gulf region, we have got 25, 50, and 100. So is that what to do with that? What would be the best way? Should we give them like different doses on alternate days, or what would be the best solution for somebody who's requiring, for example, 75 milligram? So in that situation, what would be the best way of giving them?
I usually,
Alternate days or cut the 25 microgram tablet with a tablet cutter. Because even if they took slightly more today and slightly less tomorrow, it will balance itself over the week.
Okay.
Alternate days is an easier option.
Okay. All right. Could we give them that on the weekend, for example? Maybe a better compliance?
Yeah. I mean, it depends on what is the total weekly dose that you need. So sometimes adjustment by once or twice a week of the dose it would be enough. So yes, all options are available. It depends on the individual.
Okay. I'm trying to skip some questions because really I didn't get the on what do they mean. And now here, this is an interesting question. What is the role of steroids in autoimmune hypothyroidism? If patient symptoms not improved by thyroxine. So again, Dr. Hussein, is this something? Does steroid has any role in those who did not improve with autoimmune
I
hypothyroidism?
don't think for hypothyroidism they have a role. I mean, if someone comes in with hyperthyroidism from thyroiditis, then in certain situations we can use steroids, but not for hypothyroidism. I think levothyroxine is the only established treatment for hypothyroidism.
Okay, excellent. So here, Dr. Muhammad, can we start anti-lipids if it is elevated immediately or wait until to normalize TSH?
I would, I mean, it depends on how high is the lipids. The impact of the high TSH on lipids is there. So I would say that atherosclerosis happens in months and years. So there is no imminent rush. If someone is frank hypothyroid, I would correct the thyroid status first and then look into the management or the lipid profile on a fasting basis.
Okay, here there are, I would say, a question with different format that the, some hypothyroid patients comes telling you that their physician told them not to take thyroxine on the weekend. So I think this is not a true. Okay, now
It might be that they need 6 days, so it all depends on the dose. So if my total dose could be covered in 6 days or 5 days, it might be an option for people to remember. Don't take the tablet on Saturday, Sunday, or something. Yeah.
Yeah. Okay. Now, here are questions which is related to the timing of the testing. Does it affect the results, whether it is a morning or evening sample collection? Please, Dr. Simon.
There is a diurnal variation in T4, T3, but if the patient is already on thyroxine, it really doesn't make much difference. The only thing I tend to prefer is the day of doing the test. I prefer for them not to take the thyroxine and then come immediately and do the test, because then you might see a higher level of T4. So I tell patients, I mean, you can have your food and everything, come in, no problem. Just do not take the thyroxine that day. And you can do it in the morning or evening. It makes very small difference. We know that there is a difference, but it tends to be not very clinically significant.
I tell them the same thing. If first of all, you should be checking at TSH is the most reliable test. But in case you're checking a free T4, then in those situations, the better to do the test either before taking the levothyroxine or at least 4 to 6 hours after taking the levothyroxine, because then they will get confused. The TSH may be normal, but the free T4 is high, and that's because I think they just took the levothyroxine.
Okay. Hey, Dr. Muhammad, do we have a maximum dose in autoimmune or post-surgical hypothyroidism?
No.
Who are taking more than 100 micrograms a day, but still it's not that target with a good
It's
adherence.
related to the body weight, and the vast majority of people would require less than 200. Very rarely would go above 200, and extremely rarely that you would go to 300. Most likely these people are not compliant.
Okay, so they have to make sure of adherence and compliance before they would take anything.
Indeed.
All right. Okay. If TSH is 7 and patient symptomatic, can we start thyroxine, or do we need to repeat thyroid function again after 3 months before start? So,
but as we mentioned earlier, Dr. As we mentioned, Dr. Saud, you have a triad of 3. The TSH, the symptoms, and the antibodies. So if the patient is symptomatic and the TSH is 7, they have 2 out of 3, then it's worthwhile to give it a go.
Okay. Now, does smoking affect thyroxine absorption? This is an interesting question. Okay, any volunteer?
Not to my knowledge.
Smoking is very interesting, actually. The effect of smoking on thyroid is absolutely, I mean, counterintuitive. People who tend to smoke have less tendency to develop hypothyroid and less thyroid cancer. Why is that? Nobody seems to know. But it does not affect the thyroxine absorption as far as I know.
I hope you're not advocating smoking.
But this
No,
is a different. Now
As
you
a
will get a
prevention
lot
policy
of.
for
but
thyroid
that
for
may be
thyroid
the
cancer.
only that may be the only positive you can find.
Okay. Now this question directed for Dr. Hussein. Elderly patient, do you recommend using T3 with T4 in case of myxedema or severe hypothyroidism?
I mean, mixed edema, I have fortunately not have too many patients with mixed edema. We can use in those certain very small situations, but generally I am not a big fan of liothyronine at all. Especially in elderly, I think that should be the last patient population that we should think about using T3. I think there was a question on the chat. If we do use it in certain patients,
Yeah.
how do we use it? So fortunately, like the other doctor was mentioning, we don't use it. We don't see a lot of people on T3 here. But in case we use it, or in case the patient really wants to use it, I would use it in a ratio of 1 to 10. Maybe so levothyroxine would be 10 versus liothyronine will be 1. So maybe they're on levothyroxine 100 micrograms versus liothyronine 10 micrograms per day.
Mhm.
So we use a combination of 1 to 10, which is close to 1 to 14 physiological ratio of T4 to T3. But other than mixed edema, very small situations, I will not recommend using T3 in older individuals. Yes.
Okay. Right. Now here TSH is 3.5 with a normal T4 in first trimester without any symptoms of hypothyroidism. Should I start thyroxine?
Sorry,
So
TSH is 3 point.
TSH 3.5 with first trimester of
The
pregnancy.
antibodies, well, actually, TSH is 3.5, so it's in the normal range, even if we adjust it. So I would not recommend starting it. But I would probably also check a thyroid peroxidase antibody, maybe, just because the TSH is on the upper side of normal. But no, not for 3.5.
Okay, excellent. I think many questions are repeated here, Dr. Muhammad, talking about rather than giving it on a daily, uh, is there a way to give it alternate days or every week or because of the compliance and adherence issue? Many
Well,
of these questions.
yes, you can. I mean, as Dr. Hussein mentioned, on rare occasions you can use it weekly. So certainly you can give the total weekly dose into 2 or 3 doses per week. That's not a major issue. The concern obviously would be in vulnerable people, such as those with cardiovascular disease and of the older age group. But in theory, from bioabsorption and total effect over the week, it's a possibility if it's done in a safe hand.
Okay, excellent. So we are hearing it more than one from all our eminent speakers that again it can be used with caution and very limited cases. Okay, here, Dr. Simon, when do we screen TSH in pregnancy? In which trimester should we screen? And do you recommend like a massive screening for all pregnant ladies?
Actually, it's a controversy. The American College of Gynecology, they do not recommend. The gynecologists do not recommend, which I find very surprising. Because this is something that can affect intellectual development of the baby, which is going to last a lifetime. So, I mean, I go ahead and check all ladies who are planning pregnancy, and ideally, we should check it, a couple of months before the planned pregnancy, so that if it is abnormal, we can get the TFT to be normal before they get pregnant. Because oftentimes, by the time the lady figures out that she is pregnant, it's already 1 month up, and it's a critical time period. We know that even though the thyroid starts forming, much earlier, the production of the hormone is not really ideal up to about, by only about 36 weeks does it really reach the adult levels. So all along the way we need treatment with thyroxine, and the earlier we start the better, and we must continue, and definitely we should check every month. So before pregnancy and the moment you find you're pregnant, you should check it immediately, because then again there is a jump in the TSH most of the time. So we might need to increase it again. In fact, in countries like US, where the access is much limited compared to us, We used to tell
Mhm.
the patient to increase the dose by 20-25% automatically once you suspect you are pregnant. So that is
Okay.
just to be on the safer side. We are
Okay.
actually luckier because we have access to doctors.
Okay. Now, this is maybe very specific questions for people who are going under post-thyroidectomy. When do we start thyroxine replacement for them? So people who are planned to have thyroidectomy, when do we plan to start them on thyroxine?
We can, in our hospital, we start them the next day. I mean, there's if they've had thyroidectomy, there's no. I mean, if you wait until for 2 or 3 days, maybe after discharge, they may miss taking it. So it's better to just start the next day. It's fine.
Okay. Just to
I would
continue on
just
this,
like to,
what
yeah,
dose do you use? Yeah.
I would just like to add, if the patient, let's say, has thyroid cancer, and many a time, if they are going for treatment with radioactive iodine in a short time period, then I generally do not start. If they are going to use a withdrawal thyroxine instead of going with using recombinant TSH. Many times recombinant TSH is not covered by insurance. So in which case, I do not restart after thyroidectomy. Usually, I mean, once we make sure that pathology comes back, if it's benign, then I start on discharge. That's what
Okay.
I do.
Excellent. Excellent. Dr. Muhammad here, a child who's obese with high TSH. Do we need to treat him? Dr. Muhammad, uh, we cannot hear you.
Sorry, I'm not a pediatrician,
Okay.
but I'm not aware that there's a difference in diagnosis according to age. If they are hypothyroid, they are hypothyroid. But if the TSH is only raised, but 3 to 4 is normal, then I would apply the same principle. But I'm not qualified to give a full answer on this. I don't know whether if my colleagues can have experience with pediatrics.
All right. Yeah, usually in those we do treat them. Always again it's a weight dependent. So according to weight we treat them if they have got high TSH. Even in those who are subclinical, this is one of the indication to manage them because they are during their growth. Yeah. Okay. Now this is an interesting question. What are the indication to treat those with non-thyroidal illness patients? Do we have any indication to give them thyroxine for those who have got non-thyroidal illness?
Treat the cause.
Okay. All right. Is that okay? Fine.
We don't
Now,
usually give in non-thyroidal illness. Actually, it may be more harmful to give levothyroxine if they're critically ill patient than beneficial. So maybe just the
okay.
body's response that the thyroid is functioning that way, so we don't have to treat it.
Okay.
In fact, there
Excellent.
was some trials that was done, about 35 years ago in patients who were in the ICU. All of them tend to have low T3. And Dr. Irving Klein and group in New York, they treated them with T3, and there was no benefit at all, even in those with very low T3. So no benefit at all in non-thyroid illness.
Okay. Another interesting question. In people who had been on thyroxine, but still they feel weak, fatigue, is there any rule to add or combine with them T3? Okay, maybe this would be
I think we both recommended on this, Dr. Hussein and myself. Guidelines do not advocate the combination of T3 and T4. Weakness and tiredness and fatigue are very common symptoms for so many reasons. And that's what I try to say to my patients. If your TSH is normal, then your symptoms are because of something different.
I think I have to stop here. Believe me, I learned from those questions more than what I've learned from my excellent and senior colleagues. So they've been asking in all directions. I think now I'll be mastering hypothyroid, and I should have no reason to not to to have a full mark in hypothyroid and to manage them. So again, thank you very much for such a great faculty that I was having, Dr. Simon, Dr. Hussein, Dr. Hassanin, for being with us tonight, for those big audience that we had, for the gate, for their endorsement, and for our sponsors, Merck. And again, remember that you have always to suspect in order to manage people with hypothyroidism. Now, again, this is an invitation to attend the annual Congress of Gulf Associations of Endocrinology and Diabetes, which is going to be on 24th to 25th of October in Conrad, Dubai. Thank you very much for all of you. Really, I enjoyed every minute of this evening. Thank you very much for all of you, and hope to see you very soon somewhere. Thank you.